Okay, so we started recording right now. Let's move to our lecture. So we will talk about several diseases today. I'll try to highlight things for you, and some topics you may need to do with self-studying. If we talk about the hypertensive eye disease, we need to differentiate two things: accelerated hypertension or acute hypertension, like for example cases with preeclampsia, or cases with pheochromocytoma, or cases with what else can cause Cushing syndrome. Those patients usually will have we call it a reflex vasoconstriction of the retinal vessels, because they have what we call the autoregulation, and we can find signs of that. Long-standing hypertension causes sclerosis of the blood vessels, which causes the famous signs like AV crossing changes, or what we call nipping or necking. Accelerated hypertension, in addition to causing the vasoconstriction, can cause breakdown of the blood retinal barrier, inner blood retinal barrier, which can lead to hemorrhages or edema. The signs can happen in the retina, optic nerve, or the choroid. The retina, we have grades. So grade 1, mild generalized narrowing; grade 2, focal narrowing. So something like that, you find that the vessel is narrowed. Here is a generalized narrowing of the vessels. Here is the focal narrowing in response to the increased intra arterial blood pressure. Sometimes there is the copper wiring or the retinal hemorrhages in stage 3 or 4. Sometimes there is leakage in the form of hard exudate or macular star, something like this one. So whenever you are asked to examine a patient with accelerated hypertension, you need to focus on the blood vessels, especially the arterioles, and focus on the AV crossing crossing areas to see if there's any AV crossing change. This is usually more common with chronic hypertension. You should look for soft exudates, retinal hemorrhages, hard exudates, and macular star formation. As you may notice, microaneurysm is not a feature of pure hypertensive retinopathy. If you find microaneurysm, there is an element of diabetic retinopathy in addition to the hypertensive retinopathy. Optic nerve change usually occur in very, very accelerated hypertension or malignant hypertension. If you find disc edema, this indicates that the patient, is having a very sharp rise of the arterial blood pressure. The choroidal changes include what we call the fibrinoid necrosis. So in the histology, it looks like eosinophilic material like that in the choroid, and it comes in the form either of streaks affecting a choroidal blood vessel, or a spot like that, what's called the SEROUS streak or Elshing spot like that. You need to know those things when you are looking at the fundus of those patients, okay? And in extreme cases, they may have exudative retinal detachment. So this is how the SEROUS streak looks like, and those are the Elshing spots. They look like that. Sickle cell is important for those who will work in the Gulf area. It's very common there because of the consanguinity there. You can read it in the book, but the important things is the pathophysiology. Those patients usually, due to hypoxia and acidosis, will have the sickling of the blood vessels, which can lead to vascular occlusion. What we need to know is sickle cell is more common in sickle cell disease, in sickle cell C disease, and sickle cell thalassemia disease. Don't use carbonic anhydrase inhibitors in those patients, because it will accelerate the sickling and the vascular occlusion. There are some anterior segment signs. The most important one to us is the hyphema. Usually you should ask for a history of or the presence of sickle cell anemia in patients with hyphema, because they need a more aggressive treatment. The retinopathy can be non-proliferative or proliferative. Those are the important things. The veins may show tortuosity, arterial changes like vascular occlusions. What we call the optic disc sign of sickling. We have those small reddish dots. that may be mistaken for neovascularization of the disc in patients with diabetes. Those are due to small vessel occlusion. The posterior segment changes can be non-proliferative or proliferative. The pathophysiology is there is vascular occlusion, which can lead to superficial retinal hemorrhage and can give this preretinal hemorrhages, or can have some sciatic cavities with refractile deposits in the retina when they resolve, and or they there may be what we call the retinal pigment epithelial changes, giving those what we call the black sunburst, something that looks like that. And of course, angioid streaks like these ones, they are common. The angioid streaks, whenever you find them, think about pseudoxanthoma elastica, or think about Paget disease of the bone, or think about hemoglobinopathy is one of them in the sickle cell. And of course, the main complication of those angioid streaks that they may cause secondary CNV formation. Proliferative, it goes through stages from 1 to 5. Starting, the most important thing is what we call the C-fan neovascularization. They look like this, very similar to a C-fan, and they may progress to vitreous hemorrhage and tractional and rhegmatogenous or tractional rhegmatogenous retinal detachment. They are very similar to diabetic retinopathy, peripheral vascular occlusion. So you see peripheral ischemic retina, C-fan configuration of the new vessels that leak in the late phase of the angiogram. And of course, the treatment is by peripheral panretinal photocoagulation. But sometimes they may improve on this on their own. So sometimes some practitioners may advocate observation of those vessels, aiming at spontaneous occlusion of those new vessels by the sickled blood, red blood cells. You may need to do laser or cryotherapy of the peripheral ischemic retina to help the involution of those new vessels. Or sometimes the laser treatment is done to the feeder vessel. So here it's a bit different to the diabetic retinopathy, that you may want to treat the feeder vessel to help the involution of the new vascular tuft. Vitreoretinal surgery may be needed if there is tractional retinal attachment or non-clearing vitreous hemorrhage. Always try to avoid scleral buckling in those patients because it increases the anterior segment ischemia. So whenever the patient develops rhegmatogenous retinal attachment, it's important to remember, avoid carbonic anhydrase inhibitors, avoid scleral buckling in those patients. Okay. Moving to another important subject, which is the retinopathy of prematurity. It's becoming more and more important now because more of those premature infants can survive now. In the past, we used to tell the parents that the oxygen treatment is the main risk factor of developing retinopathy of prematurity, but nowadays things change. So we now tell the patients that, or the parents, that the prematurity itself is the main risk factor. So let's say I have 2 kids, one of them has low gestational age, let's say born at, let's say for example, 27 weeks of gestation, and he did not need prolonged oxygen therapy. The second one is born, let's say, 34 weeks of gestation, and he needed prolonged oxygen therapy. I'm more concerned about the one with the small gestational age. This is more, relevant to development of retinopathy of prematurity. Now, because the oxygen levels are more monitored, or what we call oxygen curtailment, so the neonatologists don't give liberal oxygen, the oxygen importance has diminished nowadays. We need to know that retinopathy of prematurity is a biphasic disease. So in phase 1, when the patient is born, just coming from the intrauterine life and breathing oxygen will cause what we call relative hyperoxia. So the oxygen levels will increase, and this will cause damage of the peripheral retinal capillary bed, because the hypoxia is important for this capillary bed to develop. And this will cause what we call the retarded blood vessel growth. This is phase 1, which usually developed in the first 4 weeks. Afterwards, this ischemic retina will start to suffer hypoxia and will produce vascular endothelial growth factor and will promote abnormal neovascularization. Usually the vessel starts to grow from the optic nerve towards the periphery, starts from the 4th month of gestation, and completed, they reach the nasal retina at the 8th month of gestation and the temporal retina at birth or 1 month after birth. So patients with prematurity, they don't have complete growth of those new vessels. The most important thing is who should be screened for retinopathy of prematurity. Each country has its screening protocol. Here in Egypt, we are still not having our protocol, so we try to widen the number of the patients, or increase the number of the patients that we increase. It's well known in the literature that patients in developing countries can develop ROP even with larger gestational age or larger birth weight. So if you will see in Western countries, you'll find that they screen for patients with 32 gestational age or less, and with 1,500 grams of birth weight or less. Here in Egypt, as a developing country, we screen from 43 weeks or less and from 2 kilos or less, because we still can find ROP in larger infants. Is that clear for you? So those numbers are really important to know. Okay?
Okay, Dr. Islam.
Okay. We follow what we call the international classification of retinopathy of prematurity. You should know that signs of retinopathy of prematurity can be either an active disease or cicatricial disease. The active disease is the one that we see frequently, and is classified according to international classification of retinopathy of prematurity. We talk about the zone. Zone 1 is the most central part. If we have a zone 1 disease, this means that the blood vessels did not cross the zone 1, which is roughly represented with a circle. This circle is focused around the optic disc, and it has the diameter of double the distance between the optic disc and the center of the fovea. So this is one area, one distance, and we take another distance and draw a circle around that there. And it, how can we see it clearly, clinically? We use the 28 diopter and look with the indirect ophthalmoscope. Put the optic disc at one edge of the view. Roughly the other edge of the view is the edge of zone 1. So if you see the blood vessels are extending beyond that, it's going into zone 2. Zone 1 disease is the most severe form of the disease because we still have a large area of ischemia of the retina. On the contrary, zone 3 is the very mild disease because most of the retina is vascularized and you have only a small area of ischemia. Zone 2 is a ring-shaped area extending to the nasal retina, and we have a crescent-shaped area. This is zone 3. Why do we have zone 3? Because the vessels reach here by 34 weeks of gestation, but to reach here, it goes up to 40 weeks of gestation. So there is a bit of difference in between them. Okay? Is that clear for you? Let's move to the staging. So we have stage 0, which is just incomplete vascularization. So you find that the vessels are going like that and then terminate without any differentiation between the vascular retina and the avascular retina. This is called stage 0. Then we have stage 1, which is characterized by what we call a demarcation line. So you find a deposition of a bit of glial tissue between the vascular retina and the avascular retina. And we have what we call the brooming of the vessel. We find that the blood vessels start to divide and have a broom shape like brooming, يعني مقشة. Okay? Stage 2, it's called the ridge. So it's something that looks like that. The glial tissue is not flat. It has width and height. Okay? Stage 3 is what we call the extraretinal neovascularization. So it's not just glial tissue, but there is abnormal neovascularization that started to develop here. Okay? Stage 4 is incomplete retinal detachment. So you have contraction of the glial tissue, which causes elevation of the retina, but the detachment is still incomplete. There are parts of the retina which are still attached. This is in contrast to stage 5, in which the retina is completely detached. You know, this disease, when it was first described, it was described as retrolental fibroplasia. So you find that the retina is fibrosed and pushed just behind the crystalline lens. If you examine this patient with a handheld slit lamp, you'll find that the crystalline lens is clear and there is fibrosis behind the crystalline lens. Okay? We have what we call the plus disease. So plus disease looks like as if there is a central retinal vein occlusion. You find that the arteries will become tortuous and the veins will become congested. Why does this happen? This happens because there is loss of the peripheral capillary bed, and there is what we call an arteriovenous shunt. So the artery pushes the blood directly to the vein, and this avoids the gradual pressure gradient provided by the peripheral capillary bed. And this is why the fundus looks angry like that. And when you find a plus disease, this is a bad sign that this patient has high risk of developing retinal detachment if left untreated. There is another entity called the aggressive posterior ROP. It can progress very quickly to retinal detachment. It's characterized by ill-defined new vessels, so there are abnormal new vessels here, and they are not present at the junction of the vascular and avascular retina like stage 3. They are present all over the retina, and the blood vessels are usually extending just to zone 1. So it's characterized by what we call a posterior location. So it's more common in the zone 1. There is aggressive plus disease. There is ill-defined blood vessel, and these infants should be treated very, very aggressively. Okay. So we had what we call the early treatment retinopathy of prematurity clinical trial. This is a multi-central trial which gave evidence that the laser treatment is safe and effective in those children. And it described what we call the pre-threshold ROP. We have type 1 pre-threshold ROP indicated for treatment. You find the rule is the disease is more aggressive and needs more treatment if it goes to zone 1, if it's stage 3 or more, and if there is plus disease. So there are combinations which require treatment, but the main rule that we should keep in mind that stage 3 or more usually requires treatment, plus sign usually requires treatment, zone 1 usually requires treatment. Type 2 is less severe form of the disease. It requires just close observation. You'll find that it is very similar to type 1, but it's still a bit less severe. So let's say if there is stage 1 or 2 without plus disease in zone 1, this requires close observation, because if it either will go to stage 3 or if it will develop plus, you'll need to treat this infant. And we may need to see those patients every 3 or 4 days to see if they will progress to type 1 or not. Okay, here, for example, can anyone classify this eye for me? What is the stage here? What do you think the stage is?
Stage 3.
I will say that I'm not seeing frank neovascularization. Maybe there is a bit here, but I'm not sure about that. So I'll say more or less it's still stage 2.
Stage 2 plus.
Stage 3, sorry?
Stage 2 plus.
Stage 2 plus, there is a frank plus disease here. And what do you think about the zone here? So here we have the disc, here we have the fovea, and
Zone
here
2?
is a second, double the distance will be something here. So this is zone?
Zone 3. Or...
Zone 3 is very far peripheral. Let's go back to this one. Just a second. Here, this is double the distance. This is zone 1. Zone 3 is the very, very far peripheral. So here, it's just double the distance. Disc, fovea, and this is double the distance. So it's still zone 1. So it's a plus disease in zone 1 with stage 2. If you look, it's indicated for treatment. Let's take another example. Let's talk about this one, for example. Here, disc, fovea is something here, somewhere here, and here is the edge of zone 1. So it's very, very posterior in location. It even didn't come close to the junction between zone 1 and zone 2. And of course, there is plus disease here, and still there is no I'll say that there is a very early line here probably, or even there is no line. So I'll say stage 1 plus, but because it's very posterior location, so I'll say that this is aggressive posterior ROP, which requires urgent treatment. Okay? The other thing that we need to keep in mind that usually the screening should start at least 4 weeks after birth. We should not screen those infants immediately after birth, because in the early 4 weeks, there are still no signs of ROP. You'll find that there is incomplete vascularization because it's phase 1 of the disease. Okay? The other thing that we need to know, those infants are screened under topical anesthesia. We don't need to give them general anesthesia. Okay? We dilate them very well, use topical anesthetic drops, use an infant-led speculum, and examine them with an indirect ophthalmoscope. Can we use a direct ophthalmoscope to examine those infants? What do you think?
No.
Why?
الزونز البريفري بتاع الريتنا اكتر.
Exactly, because it's a peripheral disease and you need the wide field of the indirect ophthalmoscope in order to check the peripheral retina. Okay? The direct will not do the job here. Okay? We need to know that even after complete vascularization of the retina, those infants are more prone to refractive errors, strabismus, amblyopia. So, you know, we need to keep a long-term follow-up of those infants. The treatment, in the past, we used the cryotherapy, but this is obsolete now. Sometimes we do laser treatment. As you can see, we use the indirect ophthalmoscope and we aim the laser bursts to the peripheral ischemic retina. It's very similar to the philosophy of treatment of proliferative diabetic retinopathy. You want to ablate the peripheral ischemic retina in order to decrease the vascular endothelial growth factor and causing regression of the abnormal new vessels. Recently, we started to shift the treatment to intravitreal anti-VEGF, and we have 2 important studies. The BTROP study, which studied the efficacy of bevacizumab, the Avastin, and the Rainbow study, which studied the efficacy of ranibizumab and the safety of ranibizumab, the Lucentis. This is what we use now, and it's better for zone 1 disease. Can anyone give an explanation why injections are better in zone 1 disease? What do you think? Why do you think it's better in zone 1 disease, the injections, than the laser treatment?
Macular يعني.
Let's imagine that we will treat this infant. If you say we have an infant with zone 1 disease and you want to treat him with laser, you will do extensive laser treatment, very, very large number of laser shots to ablate the peripheral retina. And this infant will have long-term constriction of the field and long-term poor night vision. When you do injection, the blood vessels can extend after because usually the ROP is different from diabetic retinopathy. In diabetic retinopathy, the hypoxia is, you know, chronic and long-standing, but here in ROP it's usually transient. So there is a window in which, if you will treat the patient, usually the blood vessels will continue to grow and will resolve this ischemia issue. So if the patient, let's say, has a zone 1 disease and you did the injection, what's expected that then the abnormal vessels will regress and the normal vessels will gain time to grow towards the peripheral retina. So what we are expecting that within few months after the injection, the retina will be completely vascularized. If you do laser, you will cause permanent damage to the peripheral retina. On the contrary, injection will allow the vessels to grow and will maintain good peripheral vision. You got the idea?
معلش هو انا اتلخبطت شويه ممكن حاجه تستعيدها تاني الحته دي.
Okay. If you have a zone 1 disease, this means that the vessels are extending to that part, and all zone 2 and zone 3 are ischemic. In order to treat that, you will need to treat all zone 2 and all zone 3 with laser, which means that you will need to give very large number of laser shots and you will need to ablate a large area of the retina. On the contrary, if you do injection, what the injection does, it causes some regression of the abnormal new vessels, which allows the normal vessels to invade and the ischemic retina and grow through that. And usually it grows till the end of zone 3. So by the end of the follow-up period of the patient after the injection, you'll find that the normal vessels have progressed and extended through zone 2 and zone 3. And by the end of the day, the patient will not have ablation of the peripheral retina. It will still remain functioning. وضحت ولا اقولها تاني بالعربي؟
تمام كده. بس هو طب
تمام.
لو زوم 2 و 3 مش هيحصل بالانجكشنز؟
زون 2 و 3 بتحصل، بس الإفكت of laser treatment is less. If you will ablate that area, it will not cause much effect on the peripheral field as if you will ablate zone 3 and zone 2. It will be more profound if you will need to treat the whole of zone 2 till the edges of zone 1. Okay?
تمام، شكرا.
عفوا. We may need to do surgeries in patients with tractional retinal attachment. What we are aiming to is to prevent retinal attachment from happening, because if it will happen, the prognosis is not that good. Sometimes we have the cicatricial disease. We don't want to see something like this. This is a stage 5 ROP in which we have what we call the leukocoria or the retrolentar fibroplasia. Okay. Another important entity, the retinal artery macroaneurysm. What I need you to remember, the type of patient that have this retinal artery macroaneurysm is usually an old, frail lady suffering hypertension. If you see something like that, you may think it may be a retinal artery macroaneurysm or an age-related macular degeneration. It may present with this. The second thing that I need you to remember, that it causes bleeding at different levels. So it can cause preretinal hemorrhage, intraretinal hemorrhage, and subretinal hemorrhage. This can happen with macroaneurysm and can happen with wet age-related macular degeneration. If the patient is old and hypertensive and the blood is not at the center of the macula, it's a bit shifted towards one of the bifurcations of the retinal arterioles, think more about macroaneurysm. On the contrary, if it's central in location, think more about a bleeding choroidal neovascular membrane. Okay? So what we need to remember, the type of the patient and that it can cause hemorrhage at different levels of the retina. Okay? There are many complications, including bleeding, leakage, hemorrhage, epiretinal membrane formation. Sometimes choroidal neovascularization can complicate that. What we are aiming for, that those patients usually may have a bit of spontaneous involution of the macroaneurysm because of the turbulence of the blood flow there. The treatment, if it's causing leakage, thickening, and hard exudate, you may want to treat it with laser. Usually the treatment is not to the macroaneurysm itself. Usually you aim to treat the retina around it, aiming at accelerating the spontaneous involution and thrombosis of the macroaneurysm. Because treating the macroaneurysm directly with laser increases the risk of bleeding. You don't want to do that. Okay? Intravitreal injection was found useful in a case series, but still there is no agreement about that. You may want to do what you call the laser hyaloidotomy if there is a persistent subhyaloid or premacular hemorrhage. You want to aim the YAG laser to that area, aiming to dispersion of the blood to the vitreous space. So here, for example, the laser shot was directed to that area, and as you can see, the blood is trickling down, and the size of the preretinal hemorrhage is less than before. You may want to do intravitreal gas with tissue plasminogen activator, like what we do with bleeding choroidal neovascular membranes, aiming at displacing the blood away from the macula. Sometimes vitrectomy may be necessary if there is vitreous hemorrhage. Coats disease, you may read it as a self-studying, but what we need to do, that it's important to differentiate Coats disease as one of the causes of the leukocoria from retinoblastoma. Usually, Coats disease is more common in males. It's more common to be unilateral, and it causes, there are telangiectatic blood vessels that causes exudation, massive heart exudate, and exudative retinal detachment. On the contrary, retinoblastoma can occur in males and females. It may be unilateral or bilateral. It causes leukocoria rather than xanthocoria, so it causes more whitish red reflex. And if you find calcification, it goes more with retinoblastoma rather than Coats disease. Okay. As I said, there are telangiectatic, or what we call bulb-like blood vessels that are better seen in fluorescein angiography, but can even be seen in the colored photo or in the fundus examination. And there is extensive subretinal hard exudates. This is one of the main features. We have those telangiectatic vessels here. Okay. If you find a case with bilateral, it's not Coats. Coats is usually unilateral or always unilateral. Okay. Treatment, we range from observation, laser treatment to the telangiectatic blood vessels, aiming at decreasing the leakage, or intravitreal injection, adjuvant to the laser. Sometimes you may want to do intravitreal triamcinolone to decrease the exudative retinal detachment. Cryotherapy to the telangiectatic vessels may work. Sometimes you may want to do vitrectomy or enucleation in eyes with neovascular glaucoma. Purtscher retinopathy, you probably saw that in the night shifts. You can, read that in the book. The most important thing that it is, the pathophysiology is, it is usually due to embolism with complement-mediated white blood cell aggregation. This is something that we need to bear in mind. Usually there is some sort of embolism which with cascading the complement-mediated inflammation and causing the appearance which is similar to the hypertensive retinopathy, characterized by hemorrhages and hard and cotton wool spots, the soft exudates, etc., etc. Okay. Valsalva, again, it's something that you
دكتور اسلام مش سامع الصوت
دكتور اسلام حضرتك عامل ميوت.
تقريبا في مين.
Okay. So can you hear me right now again?
دكتور اسلام.
Okay. So I was talking about Valsalva. I remember that case who had, she was in her honeymoon, and she had her honeymoon in a country in the Far East, and she had a bungee jump, and she developed that Valsalva retinopathy after after that jump. She usually, the blood is either underneath the internal limiting membrane, so between the internal limiting membrane and the retina, or in the preretinal space, or even may break through the posterior hyaloid to the vitreous. But usually it's not subretinal. Okay. Can we go for probably 20 more minutes, or you are fed up?
طبعا اسلام.
What about the other people? It will be just 20 minutes, okay? So for the epiretinal membrane formation, what's important to notice that we have two types of epiretinal membrane: primary, or what we call the idiopathic. The theory is when the posterior hyaloid detaches from the retina, remnants of the cells remains on the surface of the retina. It's very similar that when we remove the stamp from the surface of the envelope, and you find that the surface there is not very smooth and not very regular. In those patients, there is no other cause for the epiretinal membrane formation, and the blood vessels, the epiretinal membrane is believed to be developing from the laminocytes, cells called the laminocytes. Secondary, there is usually a cause for the epiretinal membrane formation, like previous vitreoretinal surgery, laser treatment, untreated retinal break, which cause shedding of the blood, retinal pigment epithelial cells, and usually those cells are pigment cells coming from the retinal pigment epithelium and not from the laminocytes. Okay, this differentiation is clear for you. Okay, so if we talk about the morphological classification, it's either a thin membrane, which is called the cellophane maculopathy. It's as if there is a bit of cellophane paper on the retina, and on the OCT, it appears as a thin membrane on the inner surface of the retina. Or there is what we call a macular pucker, in which you find that there is a whitish glial tissue that started to deposit on the surface of the macula. And on the OCT, you find that there is extensive glial tissue there. This is a clear indication of pars plana vitrectomy epiretinal membrane peeling. But those one, usually you start to stop and think, is it causing real problem for the patient or not? Will the vision become better or not? And you only operate on them if it's causing diminution of vision or significant metamorphopsia. Okay. The Amsler grid will show distortion. OCT, this is a cellophane maculopathy, and usually the epiretinal membranes are seen better in the red-free light. So if you have an epiretinal membrane, shift to the red-free, the green light, and look, you'll find that you will appreciate it better. Okay. The treatment, sometimes we just observe them. Sometimes we do what we call pars plana vitrectomy, epiretinal membrane plus or minus ILM peeling. So we remove the vitreous first, and then we peel the epiretinal membrane, and then we remove the internal limiting membrane to make sure that we removed all the traction on the retina. Okay. The full thickness macular hole is classified according to what we call International Vitreomacular Traction Study. In the past, we had the older gas classification, which depended on the clinical examination, but the new one depends on the OCT. We have stage 0, in which in the old gas classification there is no macular hole. In the new classification, you observe just there is an oblique insertion of the posterior hyaloid to the retina, but without any disturbance on the retina itself. Stage 1A is called the impending macular hole. There is what we call blunting of the foveal depression, and you may find a yellow spot clinically. And in the International Vitreomacular Traction classification, you find that there is schisis-like spaces in the inner retina. So it started in the inner retina, and then it progresses to the outer retina. Stage 2 is an occult hole. You find that there is rather than a yellow spot, becomes a yellow ring clinically, and there is extension of the schisis to the outer retina. Stage 2, you start to have a full thickness hole, but it's small in size, less than 400 microns. Okay. Stage 3, it's a full thickness hole, larger than 400 microns, but without vitreous detachment. Stage 4 is a full thickness macular hole, larger than 400 microns, with a vice ring. So you find there is a vice ring clinically. Which stages do we operate on? Do we operate on all stages? What stages should I start to operate on? We usually start to operate if it's stage 2 or more. So if it's stage 1, there is a 50% chance that the traction will resolve spontaneously and the macular hole will close on its own. But if it's progressed to stage 2, the incidence of spontaneous closure goes down to 5 to 10%. So you probably want to operate on patients with stage 2 or more, but not on stage 1. Okay?
دكتور اسلام معلش سؤال. ستيج 1A الصورة بتاعت ال OCT اللي موجودة دي، أنا لو شفتها يعني هقول يعني في cystic spaces وحسب الهيستوري بتاع البيشنت
الفرق الوحيد ان في ده وده، ده اللي يخليك تشك. فاهم وجهة النظر ازاي؟ It looks very similar to the cystoid macular edema with diabetes, for example. The only difference that there is a bit of element of traction here. This is the only thing that may make you think probably this is not a pure diabetic macular edema, especially if the patient is not diabetic.
تمام اوكي.
Okay.
تمام.
Okay. Usually after the macular hole closure, we find that some cases may not regain a complete improvement of the ISOS junction. So you find what we call an outer lamellar defect like that, which is again similar with the solar retinopathy and the laser retinopathy. You have this is called outer lamellar defect, OLD. So the main investigation is the OCT for the macular hole, because it helps you to diagnose the macular hole and make sure it's a full thickness hole rather than a pseudo hole or a lamellar hole, and it helps you to stage the macular hole and have an idea about the prognosis after surgery. For cases with stage 1 macular hole, there is what we call the Jetria injection or the ochriplasmine injection, or what we call the enzymatic vitreolysis. This material, it's expected to cause lysis of the collagen.
الصورة عندي ثابتة وحضرتك بتشرح في أنهي جزء؟ أنا عندي الجدول بتاع الستيج 1A 1B 2 لو كل الناس يبقى
Is that the case with everyone?
ده انا
عندي مظبوط.
طب هطلع
دكتور وليد ايه الاخبار؟
لا أنا عندي ثابتة ما بتتحركش.
طب حاول اطلع وادخل تاني، استناك. So the whole idea that you need to know things even if we are not using them, you need to know them for your exams and for your ها دكتور وليد الدنيا مظبوطة؟
تمام دكتور اسلام.
تمام. So you need to know about the ochriplasmine or the Jetria. We cannot use it for advanced cases of macular hole. We only use it in early stages of macular hole. Stage 2 or worse, we go for surgery. Surgery in the form of pars plana vitrectomy, ILM PVD, ILM peeling, or recently we do what we call the ILM flaps and the ILM grafts, etc., etc. Okay. An entity which is becoming more and more important now is the vitreomacular traction. This is more important after we started to study the macula with the OCT. So we have what we call the IVTS classification. We have what we call the vitreomacular adhesion. As you can see here, the hyaloid, the posterior hyaloid, is incompletely detached, but without any significant traction on the retina. This is called the vitreomacular adhesion. Okay. If it started to pull on the retina and giving this appearance, this is called the vitreomacular traction. Both vitreomacular adhesion and vitreomacular traction can be focal, what we call the area of adhesion or attachment less than 1500 microns, which is equal to the size of the optic nerve head, or it can be broad if it's more than 1500 microns. Then if the vitreomacular traction progressed, it may progress to a full thickness macular hole like that, which may be small, medium, or large according to the size in microns. Okay. Sometimes in your exam you may get a case like that in the MCQ question, and you are asked to give the IVTS classification, whether it's vitreomacular adhesion or traction or full thickness hole, whether it's a focal or a diffuse. So this is something that you may have in your exam. Okay. Another entity is the lamellar macular hole. Lamellar macular hole is a partial thickness hole, so it's not a full thickness hole like the full thickness hole. I just want to show you something. Just a second. What's the difference between the lamellar hole and the pseudo hole? This is something which is important to understand. Just give me 1 second. So a lamellar macular hole usually looks like that. This is the best photo. It's described as an anvil-like, an umbilicus-like distortion of the retina. It's not a full thickness hole. The outer retina is still there. And usually it's something like due to a rupture of a cystoid macular edema cyst, or due to abortive full thickness macular hole formation. So the posterior hyaloid starts to pull on the retina, cause disruption of the inner retina, and then the adhesion is resolved and give this appearance of this lamellar hole. Let's see this one. This clearly demonstrates the difference between the lamellar hole and the pseudo hole. This is the anvil shape like of the lamellar hole, and you notice that this thickness of the remaining part of the retina is thinner than the normal retina. On the contrary, this is a case of a pseudo hole. In the pseudo hole, what happens is that there is an epiretinal membrane formation, which causes thickening of the retina in the perifoveal area. So the fovea is normal, but the retina is pulled towards this direction and towards that direction. And you find that this area equal to the normal thickness of a normal retina. So there is no loss of tissues here. And this is why it's called a pseudo hole, because it's not a true hole, but actually the tissues of the retina are pulled this way and that way, which gives this false appearance of a retinal hole. Is that clear for you?
Sam.
Okay, anyone doesn't understand the difference between a lamellar hole and a pseudo hole? So what do you think this is? Is it a lamellar hole or a pseudo hole?
A lamellar hole يا دكتور.
I'll say this is a lamellar hole. I agree with you, because usually there are cystoid spaces here that started to break. The thickness of the bed is thinner than the normal retina, and this anvil shape like is very characteristic of the lamellar hole. You can still see that there are some cystoid spaces here which have not yet broken to the big cyst here. So this is why we say that this is a lamellar hole rather than a pseudo hole. Okay, let's go back to our presentation. Central serous retinopathy, more common in males, more common in patients with steroids, very important, stress, etc. What I need to stress here, that usually patients will improve on their own, and only small percentage of patients will go to what we call chronic CSR. We need to differentiate between recurrent CSR and chronic CSR. Chronic CSR, there is one source of leakage that did not improve over 3 to 6 months. Recurrent CSR, usually the patient will start to have an acute attack and then it resolves, and then another acute attack and it resolves. Okay? The detachment in the CSR can be a neurosensory detachment, or a retinal pigment epithelial detachment, or combination of both of them. You know the difference of the two types of detachment on the OCT? The retinal pigment epithelium is usually described as a dome-shaped detachment like that, involving the retinal pigment epithelial line. The neurosensory detachment usually has an acute angle rather than a right angle, and usually it's above the retinal pigment epithelial line. Okay? The FFA is important here because if the leaking point is away from the center of the fovea, I can do laser treatment directly to the leaking point. If it's close to the center of the fovea, I'll be hesitant to perform laser treatment, and I may advise the patient to wait or to have another form of treatment. This is why The fluorescein angiography is important in those patients. Patients with recurrent CSR may have this, what we call the thick retinal pigment epithelial appearance like that. Many focal areas of leakage, okay? And they may have this, what we call tracks of fluid that goes with the gravity. So the leakage starts from here, and by gravity, it leaks down, okay? Treatment can be with oral spironolactones, the aldactone, stop the steroid treatment, subthreshold micropulse diode, photodynamic therapy, because one of the theories that there is congestion of the choroid that causes this leakage through the retinal pigment epithelium. The photodynamic therapy is expected to decrease the choroidal congestion. Intravitreal injection, but there is no agreement about them, so we are not sure. There is no large randomized control trial to prove that the anti-VEGF is useful in the CSR. Okay. Degenerative myopia, another important topic. We have what we call the tigroid appearance. It looks like that because of the atrophy of the retinal pigment epithelium and the retina. And what we can see here are the large choroidal vessels. We can have what we call the focal or the patchy choroidal atrophy. We can have what we call the temporal crescent of chorioretinal atrophy temporal to the optic disc. We have the lacquer cracks. The lacquer cracks are those small retinal pigment epithelial changes in which the Brooks membrane is brittle. It can be broken easily, and with development of myopic CNV or myopic macular hemorrhage. We have what we call the Fuchs spots. It's usually can develop at the site of a previous myopic macular hemorrhage, is pigmented and elevated. The patients may have a posterior staphyloma. So here there is dipping of the posterior sclera and the retina because of the staphyloma. Patients are more prone to have rhegmatogenous retinal detachment or myopic choroidal neovascular membranes. Recently, there was an EGVRS meeting in which we discussed a new classification of the pathological myopia called the ATN classification, which classifies the condition according to 3 variables: atrophy. So if the patient is having a diffuse atrophy like that or a patchy atrophy like that, the T stands for traction on the OCT if there is a significant traction or foveoschisis, and N stands for the neovascularization if the patient is having neovascularization like that. I think it's present on the EGVRS Facebook page, and I'll try to download the meeting and upload the lecture on my YouTube channel. I think it will be useful for you to check that. Okay, sometimes. I'm just admitting Walid again. The patient may develop a foveoschisis, a myopic macular hole, or a myopic macular hole retinal attachment like that. Angioid streaks, as we said, it's more common with pseudoxanthoma elasticum, Paget disease of the bone, hemoglobinopathies, and usually they appear as orange streaks emanating from the optic disc. The main problem that they may develop secondary choroidal neovascular membrane or choroidal rupture at those areas. CHORIORETINOPATHY, as I told you, there's what we call the outer lamellar defect. So when you see something like that on the OCT, think about solar retinopathy, think about laser retinopathy, think about treated macular hole or aborted macular hole, and usually it shows that defective ISOS junction. Okay, so that will conclude our lecture. I tried to summarize things and highlight the important things. If you have any other problems, please don't hesitate to contact me. I'll try to download the recorded lecture and put it and give you the link. And please try to have the cases ready by the end of December so that we will, discuss the cases. Okay. At the moment, do you have any other questions or concerns?
شكرا دكتور اسلام.
Okay. All the best. And as I told you, if you need anything, don't hesitate to contact me. Okay. وآسف إن أنا سهرتكم. Sorry for keeping you that late. Okay. تصبحوا على خير.
شكرا دكتور.
حد عايز يسأل حاجة؟ تحت أمركم. Anyone would like to ask anything? Okay.
شكرا دكتور اسلام.
Okay. Good night. السلام عليكم.
عليكم السلام.